let me start by some of the studies I've been involved in. So, Savoir was a randomized phase 3 trial of a MET tyrosine kinase inhibitor, savolitinib, versus standard sunitinib. 180 patients supposed to be randomized. Unfortunately, the study closed after 60 patients, but provided some evidence that targeting MET through savolitinib was a very reasonable approach in papillary renal cell carcinoma patients that have MET alteration, and that's 30 to 40% of all papillary RCC. They have a chromosome 7 duplication, MET mutation, or amplification. So the response rate was 27% versus less than 10% in savolitinib versus sunitinib treated patient respectively. And the hazard ratio for progression-free survival was 0.7 and overall survival 0.5, all favoring savolitinib. And the side effect profile favors savolitinib. Obviously, you cannot draw conclusion from a 60-patient trial, but hopefully there'll be, another attempt to introduce savolitinib in the papillary RCC patient that have MET alteration. Another study I have been involved with is FRACTION-RCC. FRACTION-RCC, actually, it's an innovative design where it's part of a very large protocol where we built on a backbone. The studies with Bristol Myers Squibb, you build on a backbone of nivolumab, and then you add all these potentially very promising checkpoint blockers and immuno-oncology drug. And you have two tracks in each protocol. Track 1, patients who have not experienced checkpoint inhibitors before, previously untreated with checkpoint inhibitors. And track 2, patients who progressed on prior checkpoint inhibitors. And we build in a strategy to report now on the second cohort, on the second track. So we had 46 patients progressed on prior immune checkpoint inhibitor that received nivolumab in combination with the CTLA-4 inhibitor, ipilimumab. What we show was no complete responses and a partial response rate of 15%, and the combination was tolerated. So this is interesting in a way to show that the combination, even in prior immune checkpoint inhibitor, do have responses, but this is not at all near the combination, the same combination in patients with RCC, clear cell RCC that are untreated, that stayed after many data cut off and follow up, stayed at 42%, and the complete responses at 10-11%. And at the same time, there are, in a relation, two studies reported, one by Dr. Atkins and McKay, that asked the question in untreated patient whether we could add IPI after nivo based on responses. If you have a response to nivolumab, you do not need maybe ipilimumab, but if you don't, you have a stable disease or progression, you add ipilimumab. Dr. Atkins' study, the HCRN study, uses 4 doses of ipilimumab, and Dr. McKay's study uses 2 doses of ipilimumab. In both situations, the complete responses with, the salvage, approach was very low, and no complete responses seen. Again, suggesting if you really want to use nivolumab and ipilimumab, the PD-1 and the CTLA-4 inhibitor, you should use them together, preferably in untreated patients. So I think these are powerful studies. There's also one study presented by Dr. Klimek, which is Keynote 426 update. This regimen, well known, approved in renal cell cancer frontline, hazard ratio for overall survival from the first publication was 0.53. So a very powerful combination. And at ASCO 2020, the update was done for 23 months and showed the similar result. The PFS was maintained, and the OS was maintained. Also, the hazard ratio, probably due to subsequent line of therapy, went up from 0.53 to 0.68. The interesting thing about that combination of VEGF-IO, Pembro, Axi, as well as nivolumab, ipilimumab, is that if you look at those 20% of patients that have IMDC favorable risk, and you look at the overall survival hazard ratio, despite that these studies were not built specifically in the favorable risk, the hazard ratio with more follow-up, is more than one, begging the question, do patients with favorable IMDC risk group need both drug? Do they need VEGF-AO or IO-IO? Maybe they need one modality, the TKI or even the IO single agent. And we know less side effects with one drug than two drugs. An open question, no doubt. So very exciting ASCO 2020. I think the organizer and the ASCO staff did a very good job knowing this is, everyone was scrambling, for this virtual. There was a huge social media presence, and hopefully, the result will be disseminated. And, ASCO 20 will continue with the education program that is planned in August.